Okay, thank you for allowing me to share my thoughts with you. Um, this is this is paper of my observations after being in the physiology business for over 30 years and having done over 1,000 manometries and reviewed 1,000 echocardiographies and seen these patients. So it is not based on data, but observation. So that's the disclaimer. So the paper which you have a copy of will be published momentarily in Diseases of Colorectum. And if you had a chance to read the paper, you can now close the Zoom and go have coffee. Well, it's lunchtime, I'm sorry. So I just want to stress what Galileo said, that the names and attributes accommodated to the essence of things and not the essence to the names, since things come from, like, you're blocked out, and names afterwards. And I think this is the crux of the issue with the Nismus. People are trying to fit things into the name rather than really describing what is. So although I acknowledge the honorifics bestowed on me, I prefer the verb profess, not the noun. So historically, profess really means to declare openly. And since we are a community of equals, for me, Lester will work without the professor. Thank you. So my personal bias is that anismus is overdiagnosed, misunderstood, and poorly treated. And it is impossible to move, at least in America, with the electronic medical record, it is impossible to remove the diagnosis once it's on your chart. And it will follow you forever. And it will cloud people's opinion of your medical condition because they will see Nismus on the chart. Gastroenterologists have a very poor understanding of anatomy and do not account for anatomic explanations for their results. And unfortunately, the gastroenterologists are writing the rule books. Let me just try to. Okay, so the provenance of the term is Preston and Leonard Jones in 1985 studied patients with a poor colonic transit that had poor balloon expulsion, and on EMG and manometry showed evidence of what they defined as paradoxical contraction. This was expanded by Lebowski and King in 1995, who changed the term obstructed defecation to include abnormal anatomy and physiology. Defecography actually began in World War II to help diagnose rectal prolapse due to whipworm, which was a very prevalent condition due to the war. And then was first used in 1952, more widely, and it's used to suggest the persistence of the external anal sphincter or non-opening of the sphincter. Why is provenance important in medicine? I think you can learn a lot from how words came from and how they changed. So here's two Arabic words. Algebra comes from the word for reunion of broken parts, and alcohol comes from the Arabic word for eyeliner, which had alcohol in it in the past. The only reason I mention this is if it allows understanding of the original meaning and use, and it allows you to follow the evolution of the word and gives you insight into the thinking as use changed. I wrote an article about the next concept 2 years ago, published in Diseases Colorectum, on the maturation of a fistula, and the article was called "Who to Mature, the Surgeon or the Fistula?" And if you look at the original meaning of "to mature a fistula," which at least in the States is a very common thrown around term, original meaning was to use a cutting seton, and as the seton cuts through the muscle, it matures the tract. Somehow, unbeknownst to anybody, its current use is now to put in a non-cutting seton in anticipation of a second operation. The name has changed. People who use it now don't realize its original use. And the truth is, one can never mature a fistula with the seton. Fistulas are mature from the moment they exist. So anismus, according to the world of gastroenterology, and I said they're the ones who write the rule books, there are 3 subtypes defined by sphincter activity and propulsive forces as measured by manometry and balloon expulsion. They're now part of the Rome 4 criteria. And this is from the Rome 4 criteria. You have to have at least 2 of the following: evidence of impaired evacuation based on balloon expulsion or imaging, inappropriate contraction of the pelvic floor or less than 20% contraction of basal resting sphincter pressure by manometry, imaging, or EMG, and inadequate propulsive forces assessed by manometry or imaging. Let me go back. Okay, let me just go back here. Okay, let me go back to the slideshow. All right, so if you look at the dynamics of defecation, the rectal pressure by manometry is widely used as a surrogate for the propulsive activity of the rectum. Now, in a liquid or gas state, and I defer to my colleagues who have much more knowledge of physics than I do, but in liquid or gas state, any pressure is diffused equally along all surfaces. However, in a semi-solid state, as in the pelvic organs, peritoneum, peritoneal fluid, etc., gravitational force in a sitting position will put more pressure on the rectum as compared in the left lateral position, where the organs will tend to fall over into the gutter on the right side. So the pelvic organ pressure will be minimized. Now, what happens in defecation? This is like a 5-hour lecture, but I'm going to try to get to the salient points as relative to the discussion. One, the initial sensation of defecation happens when the stool enters the rectum, causing a defecatory reflex. You need about 70 cc's of volume in a normal patient to elicit this reflex. The internal anal will open and the rectal contractile response is triggered. As you all well know, that the response of the rectal muscles is driven by both the parasympathetic, sympathetic, and enteric nervous system, and also through brain activity, through the defecatory centers in the brain, and along with 25,000 circulating hormones and chemicals that can control all of this. So to parse it apart is extremely difficult, and I would say almost impossible. Having said that, as I said before, we know the internal sphincter opens a little bit and there's some rectal contraction response triggered. And this is actual firing of the circular muscle of the rectum, some longitudinal muscle also. And then Valsalva allows for optimal geometric positioning of the sphincter muscle to straighten the anorectal angle, which diminishes resistance to flow. Squatting maximizes angulation, and what it does, the squatting position will loosen the tightness of the puborectalis around the anorectal ring. So that's why squatting does help in defecation. And Valsalva may act to squeeze the rectum a little bit to aid in expulsion, but the direct pressure of Valsalva is dampened by the levator plate. So, Valsalva happens, it pushes on the levator plate, which pushes down. So it's sort of a muted effect of Valsalva on the rectum itself. And another factor that people really don't look at well is the viscosity of the rectal mucosa. And depending on the viscosity of it, that may affect the ease of expulsion. If you look at defecatory patterns in animals, they are very much determined by the rectal viscosity. That's another lecture. So what I'm saying is the measurement of pressures in the rectum during pushing offers very little actionable information on rectal contractility. So if you look at manometry versus anatomy, so there are many conditions that will affect the reading of rectal pressure by manometry. One, you can have a rectal mucosal, and this is here, this is the rectal mucosal prolapse, if you will, and it will push down on the ports here, giving you an actually higher number on your reading during Valsalva. If you look at an enterocele here, you can see that this small valve will also push down on the catheter during Valsalva, giving you a very high reading. And that high reading is translated into increased propulsive force in the world of the gastroenterologist, when in fact it's not. The rectocele, because the strain pressures are disseminated, will cause a falsely low rectal reading and then give you the impression of poor propulsion. So in type 1 anismus, which is the standard paradoxical contraction of the external sphincter, by current definition, you need a less than 20% decrease in the external anal sphincter pressure from baseline during Valsalva. The original definition of anismus was a more than 50% increase in the external anal sphincter from baseline during Valsalva. Magically, the definitions changed from one to the other. You can't follow in the literature how that change occurred. My sense is it was somebody decided something and put it in the literature. But nevertheless, what we have is what we have. Most of these findings will occur in 30% of normal people. And I will contend that patients undergoing manometry and defecography have some sort of stage fright. It's a very unnatural situation. And a lot of them are fear of soiling either the manometry catheter, the table, or in defecography. So many will contract their external sphincter due to fear of spillage and, like I said, nervousness. So if you think about it, I had the worst case of diarrhea in my life on the Nile, one of those little boats, and I was going to swim from the boat to land because my external sphincter was working double, triple, quadruple time. And in real life, we use 100% of the external sphincter to prevent accidents. The current definitions, as I said, are arbitrary number, not based on data. And partial contraction of the external sphincter should have very little impact on defecation. Real paradoxical motion to be measured that would impact defecation, I would suggest, is really you take the squeeze pressure on one manometry run, you take the Valsalva rectal pressure on the second run, and if the combination of those two pressures equals the pressure and maximal straining, then that suggests maximal recruitment of the external sphincter during attempted defecation with manometry. So defecography can document physical abnormalities on history and physical. I think MRI specifically should be used to document central compartment diseases, interseals, and barium defecography for internal prolapse, and not to confirm an isthmus. I would suggest that, at least for me, most diagnoses can be ascertained on history rather than questionnaires. And there are certain clues from history that are very telling on making the diagnosis, specifically the position of patients during attempted defecography. Patients with a central compartment problem, such as enteroceal, a uterus pushing back, it will tend to lean forward during defecation. And what that does is sort of tries to lift the enteroceal off of the rectum. That's a very telling piece of diagnosis that can really help you. Clearly, there are defecatory patterns, where they support their finger will give you a lot of information. And the feeling of pelvic pressure that gets better on different positions. So patients with internal prolapse or enteroceals will tend to always feel better when they lay down. The pressure will get better when they lay down, and gets worse when they sit or stand. Another telling feature for ruling out internal prolapse is the call to defecation and how often it's successful. And many patients, over half, will use their finger to determine what's in the rectum, and just ask them, is there stool there or is there nothing there? And that'll give you a lot of information on the diagnosis. Also, the physical, if done properly, will give you a lot of information. In patients suspected of an enteroceal, what I will do is a standing bimanual. It's a little awkward to do, but it's very doable. And bimanual with the finger in the vagina and the rectum, and ask patients to strain while they're standing, will give you a very good clue of whether or not you're dealing with an enteroceal or not. Similarly, if one uses the rigid proctoscopy, which is almost an ancient art form now, because everyone uses flexible sigmoidoscopy. But the way I do rigid proctoscopy in these patients is you inflate the rigid proctoscope at about 10 centimeters, and then you deflate the instrument and ask the patients to push, and you can start seeing the pattern of infolding that happens. And you keep on doing that, insufflate again at 5 centimeters, deflate. And you can start seeing the amount of rectal infolding that happens. And some of the infolding is significant enough to cause a real problem. And I have just done rectal mucosal resections for patients with just rectal infolding. And also you can sort of see an internal prolapse develop. You'll see the circumferential infolding that comes out almost to the anal canal. And lastly, a finger in the anus and ask the patients to push is many times more accurate than testing, because in doing that, the patients will think this is part of a routine exam. There's nothing special about him asking me to do that. Whereas when you start doing it when you do manometry and defecography, it takes a whole other mental head for the patient, and they start getting nervous. So in America, at least in the big centers, diagnosis is done by committee. What will happen is you have several professor types sitting in a room, and you have the data presented by several contributors. And then the history is typically taken by a questionnaire rather than one particular doctor. The data, rather than the patient, drives the diagnosis. Because the data, I would suggest, is flawed by poor technique with defecography, poor radiology reads with MR, at least at our institution, even though they're pretty good trained, they tend to miss a lot of very subtle findings with MR defecography. And then, as I said, manometry data may be flawed. So in conclusion, as I said, the diagnosis of anismus, I think, is flawed and should be taken with a grain of salt if done by standard testing questions. By standard testing techniques currently available. It is overdiagnosed and therefore poorly treated, with usually a very futile biofeedback sessions, and anatomic considerations need to be taken into account when interpreting manometric data. So physiology testing today is as disjointed as Picasso's face, and what one day might be as suggested by Rembrandt. So as science marches on and everything is confusing, this is Professor Richard Feynman, the Nobel laureate in physics, was asked this question.
This is probably going to be the most simplest one for you to answer, but what if you're wrong?
So, what if I'm wrong? I hope to be wrong. Honestly, I hope doubt is a driving force in surgery and medicine, and I hope all of this is proven wrong one day with much better testing or much better understanding of what we have. I thank you for the time, and I'll love to hear any comments or questions. Thank you.
Thank you, Professor. Please, Professor Farid, can you comment, please, on this lecture, please?
Yes.
Thank you, Lester, for this very interesting paper. It's a review article of really experienced, because you are doing your in rectal physiology yourself, and this is what we are calling for in this society. Actually, many of our members are doing this by themselves, and only they at that time we can have an idea what is going right or wrong in our methodology. If you allow me, I have a presentation to explain, because what you had mentioned was the provocation to have my work on the flow equation. It's the lack of answer, the controversy.
This meeting may be finished after 5 minutes. Would you like to shift it to another meeting
Okay. Let's let out, and then we'll go to the other link.
I'll send the link now on the email. Now I'm sending it to your email, all of you.
Okay, thank you.
Or your, okay.
Thank you.